Hello, and welcome to Bold Conversations, a 5-part series on the Immune Deficiency Foundation podcast aimed at advancing knowledge and understanding of health equity. Welcome to another episode of Bold Conversations. I'm your host, Dr. Nicole Rochester, the medical advisor for health equity for the Immune Deficiency Foundation. And I am absolutely thrilled to introduce you to today's guest. Today, I'm going to be speaking with Dr. Vivian Hernandez-Trujillo. Dr. Hernandez-Trujillo is a specialist in allergy and immunology. She has board certifications in both pediatrics, my favorite specialty, and allergy and immunology, and has 19 years of experience caring for the most delicate patients. Dr. Hernandez-Trujillo received her medical degree from Albany Medical College in New York and completed her pediatric residency at Miami Children's Hospital. She completed her fellowship in allergy and immunology at the University of Tennessee in Memphis. Dr. Hernandez-Trujillo is a clinical professor at Florida International University, Herbert Wertheim College of Medicine, located in Miami, Florida, where she serves as the medical director for the Division of Allergy and Immunology at Nicole Children's Hospital and the program director of the Allergy Immunology Fellowship Training Program. Dr. Hernandez-Trujillo is interested in education regarding pediatric allergic disease, with particular interest in the topics of food allergy and anaphylaxis and primary immunodeficiency disorders. She lectures nationally and internationally on a variety of topics related to allergy and immunology. She has served on numerous committees for national organizations, including the American Academy of Pediatrics section of Allergy and Immunology, as well as the Immune Deficiency Foundation's Medical Advisory Board. Welcome, Dr. Hernandez-Trujillo. It's great to have you.
I'm excited to be here and continue our conversation, Dr. Rochester.
Absolutely. So, this podcast series, we talk a lot about health equity and health disparities, health inequities. And today, with your expertise, I really want to focus specifically on health inequities within the field of primary immunodeficiency and among patients with primary immunodeficiency. And I know that that's an area of interest for you as well. So I'd love to start out by you just providing maybe a couple of examples of health disparities, maybe among patients that you've treated, or perhaps things that you've conducted research about, but just drawing from your knowledge and expertise in this area.
Perfect. So I think the first thing is just to review what is a healthcare disparity, right? Because we use this terminology a lot. A disparity in healthcare is when there's a difference in the medical care that is not due to differing clinical needs. So the patients have the same clinical needs or the same patient preference or the same appropriateness of the intervention. However, it's not provided the same opportunity is not provided to that patient, right? So disparities in healthcare for both racial and ethnic minorities in the U.S. are longstanding, they're well documented, and they're complex, both historic and contemporary. And that's actually the AMA's definition of the disparity. I think we've all known, and we've like talked about this before. We know that these have existed for a long time. And recently, I was actually, I had the opportunity to speak in Colombia it was last week, 2 weeks ago, about healthcare disparities in allergy and immunology. And one of the things that I talked about, it was a global health conference, and I was energized because, there was a room full of people who want to change the fact that, disparities exist, not just in the United States, but throughout all of Latin America and South America. One of the things that happened with the pandemic is, as much as there was a lot of negatives, some positives came out, right? Because we were able to clearly identify, there was no question that ethnic minorities and racial minorities they were more impacted and did not receive the same care. So I think, number one, we need to keep that in mind. And I'm going to give you an example of a particular disparity that happened during that time. Living in South Florida, you would think that if you speak Spanish, you'd be able to find someone who can speak to you in the same language. This was on the west coast of Florida. And unfortunately, I received a call from a family who I've known for many years, having taken care of one of their children. And their other child was intubated in ICU and dying of COVID. And they were desperate, but I have we have a good relationship, and they reached out to me and I said, let me see what I can do. So essentially they weren't able to communicate with someone in Spanish. They had no idea what was happening. And I was in a position where I could help them. So I said, give them the consent. And I was able to kind of be the mediator and just translate and explain to them, this is what's happening. And kind of walk through some scary days. And thankfully she was able to pull through. But that is one example of, I would certainly never expect that to happen here, but sometimes, and Dr. Rochester, sometimes we're in positions that we're able to help people for whatever the reason. They thought of me, they called me, I was so happy. And I told them, I'm so happy that I was able to help, because at the end of the day, sometimes something like that, really, it was huge. And not just for them, but for me as well, right? So it's a reminder when we were all going through a difficult time during the pandemic, listen, we're here to help. And it really gave me continued hope that we're all here for each other, because at the end of the day, that's what it's about. That's one example. In other situations where I've been, there just haven't been the amount of healthcare providers or physicians to provide the care in a way that is understandable to the patient. And whether it's in Spanish or in another language, remembering that this is important to the patient, because if they're not able to communicate, number one, you're not going to get the right type of history, and you need the history to make the diagnosis. But it's a failure for all of us. I think those are the two main disparity examples that I wanted to give. The one that happened, during the pandemic, will never leave me. That I will carry for the rest of my career, because it's just a reminder. Number one, we cannot ever you can't assume that you're going to walk into a hospital and be able to communicate in the same language no matter where you live. And it really doesn't even matter about the primary language. Sometimes it's the level at which someone is speaking to you that you don't understand. So it might as well be a different language. And I think that's also important, because disparities also occur when we make assumptions that someone has to understand the way that I'm explaining it. That is not true. We're here to provide care for our patients, and providing health care is taking that extra few seconds to make sure. One of the things that I like to ask families before I leave every room is, do you have any questions? Is everything we talked about clear? And that's the reason for it, because I want to make sure that what I said was heard and not what I think was heard. Sometimes I'll even tell them, what did you hear me say? Because I need to make sure, we're talking about complex diagnoses, complex treatments at times, and having all the information is everything for these families.
Absolutely. Thank you so much. This is a wonderful introduction. First, thank you for leveling the field and kind of starting with that centering definition. And I love that you focused on healthcare disparities, because I've shared this before. In my medical training some years ago, we knew about health disparities. I don't know that the term was necessarily being used in that manner, but at that time, everything was focused on outcomes. And there were these assumptions that Black patients or Hispanic, Latino patients or poor patients, all these things, they have worse outcomes because of something that they're doing or something that they're not doing. And it was years later when the Institute of Medicine produced their landmark study, and we really started to understand that many of these health disparities are actually due to differences in care. So I really appreciate that you started with that, and that you stated these are individuals for whom the care is really prescribed. I mean, often these are guideline-directed therapies. These are what we may say no-brainers in the field of medicine, and yet certain patients with certain identities don't receive that care. And really, if we're being honest, it's rooted in bias, it's rooted in stereotypes, and it's rooted in racism. And so I just appreciate you starting with that. And I also want to point out, I'm thankful that you were there for that patient and family. And I'm also appalled because patients and families have a legal right to have an interpreter, that is a legal responsibility that all hospitals and healthcare facilities should provide. And you and I both know that that doesn't always happen. And so it's just horrifying to think about what the outcome may have been had they not called you and had you not been able to step in. And as a professional health advocate, like that's what I do. And I love that you also mentioned the language, because often the clients that I'm helping, they English is their primary language, and they've been born in the United States, but that medical lingo that we use can be so confusing. And I forgot the exact statistics, but in terms of health literacy, someone's ability to understand the information that's presented and then use that information to make health decisions, it's something like, I don't know, it's under 40% of Americans are deemed health literate. And so you're right, we can't assume that our patients are understanding. And so I love that you asked that question. And it sounds like you use a little bit of teach back, where you say, okay, tell me what I told you, like explain to me in your words what I said. So I think all of those things are really important. Another thing I wanted to talk with you about is, I know that there's some limited research in this area, but there are a couple of published papers with regard to primary immunodeficiency and disparities, specifically among Black and Hispanic patients, with regard to, we know the diagnosis is already extremely long, but for individuals who are racial ethnic minorities, or perhaps living in rural areas or other situations where they may not have access or easy access to care, those diagnostic delays are exacerbated. And then there's even a study that shows that for patients with certain immunodeficiency disorders, particularly primary antibody deficiency, that they don't receive, patients of color, let me add that, with primary immunodeficiency, are not always receiving the guideline-directed therapy, and then, of course, have more complications. So I'd love for you to weigh in on that. Have you seen this in your practice, and if not, if so, how has that shown up in your practice? And if not, what are your thoughts about these health and healthcare disparities, specifically within PI?
I think so. One of the things that I talk a lot to my patients about is, number one, we educate about the primary disease, but we also, the reason that we lack the research and this goes back to the mistrust, the fear for immigration status, and just not knowing, like just not having the education and the information. We need we as a Latino population, we need to get involved in research. So when the research opportunities are there, we do need to take part. And we know that that has been very low, which is why when we talk about studies, right? So Dr. Charlotte Cunningham Rundles, almost 20 years ago now, used and using specific complications from primary immune deficiency, but the patients were not diagnosed. Patients of color were the highest group there, and I'm not surprised about that. They also were more likely to have Medicaid. They were more likely to be hospitalized with these complications, but not have the primary diagnosis of the immunodeficiency. The other example is, if someone who is Hispanic or African American needs a stem cell transplant, a bone marrow transplant, we just don't have the same pool, right? We don't have the same pool of donors. And that's something that is also very important to address. So one of the things that I like to say, especially if I'm speaking to a group, is, if you fall in one of those groups, please remember that we can be the lifeline. We can save someone's life, truly, not only as their physician, we can actually save them by being a donor. So these are just some of the reasons why the information is not there. It's not published, but there's no doubt that patients, there are many patients who are undiagnosed, as you said at the beginning, but more importantly, our communities need to have improved care. I can't give a specific example where I truly felt that a Latino patient maybe did they not receive the correct diagnosis, or were they not diagnosed? Yes, but I would say that happens across the board for primary immunodeficiency. But I can't say that I've had a patient where I honestly felt that it was specifically due to either discrimination or racism. I think as clinicians, we have a responsibility, right? So being the advocate, and I love to speak to pediatricians, and I tell them, look, you're our first line. If you don't think about it, then we'll never be able to make the diagnosis. So they're the most important piece really in identifying these patients, especially in the pediatric world.
Absolutely. I appreciate that. You mentioned information and mistrust, and we know that there's a lot of work to be done. And really, I feel like that burden belongs on us, healthcare providers, hospitals, health systems, in order to regain the trust that was broken, honestly. But with regard to information, we know that information is power. And certainly if there are language barriers, that's a significant issue in terms of people being able to even get the information, patients and families. And so I know that you've done some phenomenal work with the Immune Deficiency Foundation in terms of translating information and eliminating language barriers, specifically for Spanish-speaking patients and families. So I'd love for you to share with the audience about your work in that regard.
So I'm very excited that I was able to receive one of the grants for the white paper challenge, and I'm still in the process of pulling all that information together. And basically over a year, I was able to address, and it was really grassroots here in Miami, 4 different types of fairs that I attended where it was a primarily Latino population in attendance. And I think one that I would really like to talk about was, and I love this particular fair, it was not just Latinos, this was a mix of everyone. But we had, I worked with some of the medical students from Florida International, the School of Medicine, and I was so excited because they were very excited to share information about primary immunodeficiency. We went with our books in Spanish. We shared information just about, how do you take care of yourself? How do you stay healthy? And in this moment we were in the middle of flu. Unfortunately, we were in the middle of flu, COVID, there was RSV already. Because that's always in Miami. It was a great opportunity to talk to even not only the parents, but the children in Spanish and tell them, what are the important factors for immune system? Well, one of the things that I talked about, and I was excited at this particular fair, they had a truck from Feeding South Florida. They were giving out food because remember that sleep is important, and you're not going to have proper sleep if there's too many people in one room or 2 rooms and there's no beds. So that's number 1. Number 2, you need to eat a healthy diet. If you can't afford healthy food, it is very expensive. If it was expensive 2-3 years ago, it's so expensive. Feeding South Florida, I was so excited. They were, helping the families with that. Talking about the need for exercise, because that's good for your overall health, but it is good for your immune system. And then keeping in mind that stress does affect the immune system. And if you live in a situation where, and I've had patients unfortunately say to me, there's 6 of us sleeping in 2 beds and I'm sleeping on the floor and I don't have a mattress. So trying to connect those families with social work or someone or organizations that can help. The programs like WIC, women and children early on in life, they can provide healthy food for infants. And those are the types of things that we can do. So in addition to that, my second-year fellow who graduated, Dr. Steph Lidet, and I want to really commend her for her work, did really a quality improvement project looking specifically at Latinos and their understanding of primary immunodeficiency. And we found some interesting things. Number 1, so the initial survey, of course, was very low as far as their understanding about their treatment options. But after the first cycle, given some information, and then more importantly, after the second cycle, they were asked, patients and families were asked, how would you like information? Because the written form of information actually is not what they preferred. They actually preferred it in a video. And the other preference they had was for the information to be text instead of email. So for the next cycle, the information was in a video form and it was texted. And I will tell you that it was amazing to see how the numbers came close to 100, and in some cases it was 100% for their understanding of that, understanding better their disease. What are the treatment options? It was actually very enlightening. So again, keeping in mind that we can't make assumptions, right? You can say, well, why would they want it in video? Why would they want it in text? because we live in this day and age and we need to change with the times. And I think the last piece, which I'm still working on to complete the project, is I'm creating videos in Spanish specifically about different, and they're going to be short clips because that's also important, right? Not making it too long, about primary immune deficiencies for our Spanish speaking population that the immune deficiency will be able to share with everyone. So it's, this is a little piece. And I always say, this is like the tip of the iceberg. This is just one grain of rice, but every grain of rice as it continues to grow is how we're going to make a difference. And I think I'm very hopeful that that information is going to help many, many families.
No question, it's going to help so many families. I am literally like bouncing in my seat as I'm listening to you, and just thank you. I mean, I really do want to pause and thank you and your fellow and anyone else who played a role in this amazing project. I mean, what a great use of the funds from the White Paper Challenge. I want to highlight a couple of things that you said. You talked about the living conditions and like stress and eating and how that all plays in. And we've talked in previous episodes here on Bold Conversations about the social determinants or social drivers of health. So I just want to reiterate that for the audience. And it goes back to kind of where we started, when this idea of not blaming the individuals who, for various reasons, have not been given the opportunities to achieve their best health, which is literally what health equity is. And understanding that when you have living conditions such as the ones you described, you have very limited ability to achieve your best health, and it's not your fault, and so it's like, what can we do as healthcare providers, as healthcare organizations, as patient advocacy organizations to ensure that everyone has an equal opportunity to achieve their best health? And that may be resources, like you said, providing food or providing vouchers, or even making patients and families aware of the resources that sometimes are in their backyards, but they don't understand that. And the other thing that really, really lights me up about what you said is this idea of co-designing this project and you all asking the participants, how do you want this information? And the way that that information that you received completely shifted and pivoted the project, and then allowed you to get to almost 100%. In healthcare, what I see more often is that we come up with these bright ideas sitting at our boardroom tables. And then we take these ideas, maybe if we're going to do any community engagement at all, we've been in our Ivy League towers, at our boardroom tables, and then we come up with these ideas, and then we take them to the community and say, hey, community, this is what we're going to do. You like it, right? You like it, right? Let's do it. As opposed to you all pausing and saying, how would you like this to be done? And then incorporating that feedback. So I'm so excited, and I really hope that more researchers, more physicians, more healthcare organizations will take that stance as we truly engage with our patients and families and communities in a way that informs our work from the beginning. So thank you again, just thank you for that. As we begin to wrap up, I want to talk a little bit about workforce diversity. There have been, unfortunately, well, I guess it's fortunate, but it makes me sad, but there have been a lot of studies with regard to concordance, racial concordance, concordance of ethnicity, language, that basically show that patients of color tend to have better health outcomes. They receive better care when they are cared for by someone who looks like them, by someone who shares their language, their culture. And so when we take that information and we pair it with the knowledge that only 5% of practicing physicians identify as Black or African American, only 7 to 9% of practicing physicians identify as Hispanic or Latino, and understanding that those percentages pale in comparison to our representation in the United States as a whole. So we have a lot of work to do to make the healthcare workforce look like the communities that we serve. Having said that, what are your thoughts about workforce diversity, and what are some of maybe your own experiences as a Latina physician, maybe some challenges that you've had to overcome? I just love your insight on that.
So the reason why diversity, equity, and inclusion efforts are so important is exactly what you said. So as far as, physicians in the US, somewhere between 7 and 9%, but really the population is almost 18%, right? So we're double, the population's double to the percentage of physicians that are actually providing the care. I really think, so number one, we have to correct some flawed thinking, right? And I'm sure that you've also heard this. So the thinking is, well, why should we accept candidates that may not be as qualified? You're already making an assumption. So if you're given two equally qualified candidates, consider giving the opportunity to someone who may not have had that opportunity in the past, right? So the flawed thinking comes when you're already assuming, well, I'm going to accept. I can tell you, I would be very insulted, and I'm sure you would be as well, to think that someone took us because of that. That's not the reason. It's because of our hard work. And I can say that as a Latina, but I can tell you there have been different situations where, I mean, it can be in a hospital setting that and as a Latina, especially, so a female Latina, so there's two different things, hearing comments that are just not appropriate, and having the fortitude to either stand up to it or say, I'm not going to listen to this because it's not appropriate, right? So in the past, I probably would have backed down. I'm definitely getting older now, and I'm not tolerating that, because I feel like and I can't say it's happened very recently, but it has happened in the past. I'm in a situation, and I'm constantly trying to encourage young physicians, regardless of who they are, that you need to have your own self-confidence. And if something's wrong, it's wrong. It doesn't matter. And you should be able to speak up about it. So if I'm talking to a medical student, I'm talking to a resident or a fellow in training, I need to also be a role model for the people that I'm training. So if someone says something, whether it's about a female or about a Latino, I am going to say, let's stop, because that is just wrong, period. And there's no mincing words. To me, there's no need to do that. But I think it's just important to know that everything that we do is also being seen and may actually be a role modeling for someone else. So, and I think that's why maybe I have also changed. Perhaps 20 years ago, someone could have spoken very negatively about a female physician. That doesn't happen in front of me anymore, because I don't tolerate that, and no one should tolerate that. I really don't feel that I've been discriminated against. I grew up in the Northeast in Connecticut. I was very fortunate. I had a very supportive upbringing. I was a minority. There were very few, even in my own schools, there were very few Latinos. And we stuck together, but I can't say I ever felt. Now, could it have happened without me knowing? 100%. And I think the important thing is just knowing, my work has gotten me to where I am, which is why I go back to flawed thinking is just flawed thinking, that we need to give people opportunities. And patient care does benefit when someone either speaks the same language or looks like the patient. And there's no question about that. So I think just keeping that in mind. And as a fellowship training program director, I've been blessed by so many amazing, and they've been Latina, females who have gone through training in allergy immunology. And I'm blessed by all my fellows. But I think it's another example of when you're given an opportunity, and then for the young people is embrace the opportunity that you're given and make the most that you can out of it. The same way that my fellow Dr. Leida, took that I feel a very important quality improvement project, and we're going to make a difference with it. I mean, those are the opportunities that when you're given that, getting involved early, getting involved with organizations, the Immune Deficiency Foundation, I got involved with very early in my career. And whether it's the American Academy of Pediatrics or whatever, organization, Clinical Immunology Society, I think that's where we can make the biggest impact. So I encourage that as well.
That is wonderful. You're such a role model, Dr. Hernandez-Trujillo. And I just appreciate, don't frown. You all can't see her on the podcast. She's frowning, but she is. She doesn't want to embrace that. But you really are. And I appreciate your honesty and transparency. We have similar journeys, and listening to you share how as you've gotten older, you've become less tolerant of the inappropriate comments and the micro aggressions that are never micro. So I have a very similar journey as well. And I just appreciate all that you do and what you represent. And so that's awesome. Well, as we close, I'd love to hear from you if there is a hospital administrator listening, or maybe someone in charge of a patient advocacy organization, or a physician or a budding physician, what is one thing that we can do in healthcare, like today, to begin to address health and healthcare disparities in primary immunodeficiency?
I really think that we need to start early with exposure. And I mean early, getting even into the elementary schools or the middle schools and talking to children just about in general about their health, about their immune health. And, never underestimate what a young child can take from what you share with them. I think number one, you're exposing them to something that will help them lifelong, hopefully. But number two, maybe they thought, I can't be a physician. I can't get into the healthcare field. You're opening a door. So, things like STEM and those are STEAM. Those are really important programs, exposing children young to science and technology, getting in there and talking about their immune health, and anybody can really do that. Organizations can certainly get involved and partner with schools to do that in the high schools as well. And then as they move through college, they need exposure. If we don't expose, if you have no exposure, then you won't even know that opportunity is there. And you may not believe that you can do it, because not everyone has the support that I wish everybody had, right? Because whoever puts their mind to whatever that is, they can make a difference. So I would really just encourage early exposure to, and we can start with immune health, but then you can expand it to just increasing education in general about, how our patients with inborn errors of immunity or primary immunodeficiency present, because that will make a difference. And once we're able to diagnose earlier, obviously the outcomes will be better. And that's important.
I love that. And then lastly, what is one thing that a minoritized patient with PI can do today to receive better care in light of all of the things that we've discussed, all of the barriers, the challenges? If you could give one piece of advice to a Latino patient or African-American patient who is struggling to receive appropriate care, what would that be?
I think the important thing is to find someone they can trust, right? So I didn't say this earlier, but certainly in our culture, church leaders and are important. So going to someone they trust to help them find that either clinic or office or medical provider who can help them. Because when you're struggling and you don't have the information, if you're involved in a church, and we know that is important for many Latinos, that would be one way. Another way could be when you go to the pharmacy. We all go to the pharmacy when we're sick, speaking to the pharmacist and saying, look, this is what's happening. And the pharmacist really can partner and say, you need to see someone for X, Y, and Z, because to use a medicine, but not, get to the root of the problem, we're just putting a Band-Aid on. So those are the two things. And I think, certainly everyone goes to the pharmacy when they're sick because they need to get medication for something, but at least speaking to someone there, and it might be a pharmacy tech, can make a big difference as well. And just encouraging them, because once you have the trust, especially if you're going to the same pharmacy, once you trust someone, then you'll trust their recommendation. And if they tell you, go see, Dr. Rochester can help you, they'll do that. It's gaining the trust, which is the hard piece. But once we have it, cherishing that and knowing I can make a difference and not losing it, helping maintain that trust and find the best healthcare, because we're all, we all deserve that. At the end of the day, that's what we all deserve.
Well, I think that is an amazing place to end this interview. It has been a pleasure, as always, speaking with you, Dr. Hernandez-Trujillo. Thank you so much for coming on the podcast. Thank you for the work that you're doing clinically as well as research. And just thank you for, again, the role model that you are And I'm just really excited about the work that you're doing. I can't wait to see the publication that's going to result, or publications that will result from your work, and the ideas that you suggested at the end. I see many more projects in your future. So thanks again for being a guest on Bold Conversations.
Thank you so much for the opportunity. It's always a pleasure to talk to you, and I really do appreciate being able to talk about something that's so near and dear to my heart.